There are many legitimate reasons why it's important and appealing to clinicians to identify depression whenever they can. However, the enormous increase in diagnosis of depression seems to be due to something more than that. There may be quite a large increase in diagnoses due to a confusion of intense normal sadness with true medical depressive disorder or clinical depression. For the 2,500 years previous to 1980, depressive disorder had been discerned from normal sadness by context. If there was something happening in the environment that explained the reaction, so as people said, as diagnosticians always said, the reaction was with proportional cause, then you could say that's likely normal sadness. It's likely to abate of its own accord over time. But if there wasn't, if it was not related to the environment, then it was likely depressive disorder and a medical condition. In 1980, when these new definitions were propounded to try to make psychiatry more scientifically acceptable and make it more valid, it was concluded that the way to do that is just to define disorders in terms of symptoms. You can see that normal sadness, because it has many of the same symptoms as depressive disorder, they overlap, in fact they are the same kinds of symptoms, is very liable to get misconstrued and misdiagnosed as depressive disorder if you don't take into account the context of the symptoms and whether it's a reaction proportionately to the environment. One of the most disturbing trends that one sees in the data on especially primary care physicians giving out medication for people who on these checklists appear to be diagnosable as depressed is that many of the patients aren't being sent for backup evaluation by a mental health professional, and they are not being seen further, except maybe for one follow-up visit. So what you have is a virtual automatic triggering of an easy treatment by this 5 out of 9 symptom diagnosis, and then you have somebody on meds for quite a while with potential side effects, and no backup monitoring of whether this might have been a reaction to ongoing transient stressors or whether the medication is working properly and so on. Policy implications out of these data on the basis of patient diagnoses can distort the whole mental health system, with resources being siphoned in a direction that isn't addressing the needs of the truly disordered and the most severely disordered adequately, because it's being spread over a much larger population that doesn't need the resources as much.